right, this lecture is going to be about vital signs and monitoring devices. So we're going to divide this into sections throughout this lecture, gathering of vital signs, and then we'll actually talk about the vital signs, and then we'll talk about monitoring devices. Gathering the vital signs. First of all, gathering vitals is a fairly decent part of assessment process, but it does not happen until the secondary survey. So our primary survey is the first thing we do, and that doesn't include taking vital signs. That's where we find and treat the life threats. Gathering vital signs comes as a part of the secondary survey. So all of our patients should have a set of vital signs measured. This is just going to help us to find out any important conditions or treatments that are going on. It's going to help us to trend what's happening to them. That's going to help us clue in as to whether or not they're in compensated or decompensated shock. And once again, the primary assessment is for finding and treating life threats, but the secondary assessment is where we would gather vital signs. Vital sign taking. So vital signs are the outward signs of what is going on inside the body. Well, our official vital signs would include the pulse, taking respirations, count, looking at the skin, that's our circulation part, skin color, temperature, condition. And in infants and children, we take capillary refill because, of course, that is much more important indication of their condition than in an adult. Pupils, and then blood pressure taking. So oxygen saturations, we're going to get a pulse oximetry. It's pretty much standard of care at this point in time, but it's not included officially as a vital sign, but it is becoming a standard of care. So vital signs are considered baseline, which is our first set of vitals, or a repeat set of vital signs. And this is where we tend to trend our vitals. In a stable patient, you would take vital signs every 15 minutes. In an unstable patient, you would take vital signs every 5 minutes. So first of all, we're going to take a pulse. Palpable pressure of the heart beating, and everywhere that an artery goes over a bone, you can press down on that artery a little bit and feel a pulse. You feel the power of the left ventricle as it contracts, and it causes the blood to go across that or through that artery in waves. So you would take your fingertips, you don't take your thumbs, you'd always feel pulses with your fingertips. And you put that over the artery where you're checking it, and you will count the pressure waves. So when you're taking a pulse, there's two things that you're listening to or feeling. It's a rate and quality. So we're going to count how many times you feel that pulse in a minute, and then you also note the quality of the pulse. This is the guy taking a radial pulse. To count the pulse, you have to take a pulse for about 30 seconds so you get a good feel of also the regularity and the strength of the pulse. And then you multiply that by 2. So what you're trying to get is the number of beats per minute, and then trying to classify that as to whether it's normal or whether it's fast or whether it's slow. A normal heart rate in the average adult is 60 to 100 beats per minute. Anything above 100 would be tachycardia. Everything below 60 would be bradycardia. So above 150 beats per minute generally is considered more serious finding. Anything below 50 could be a serious finding also. So once again, you have to take in other factors in your consideration of that. So you have to realize what is actually going on with the patient. It would not be unusual for a patient to be anxious during an emergency, and if that's the case, that is going to increase the heart rate. So a normal situation might, for an increased heart rate, might be anxiety from an emergency. So remember to take into account condition of patient, take in medications they take that are controlling their heart rate. Don't get all caught up on one thing in a patient assessment. We have to take the whole picture. 2 factors determine pulse quality. We've got rhythm and we've also got rate. So rhythm refers to how regular the heartbeat is. So for rhythm, you could have a regular heartbeat or an irregular heartbeat. Force is the amount of strength of the pressure as it goes through the artery. So a pulse should feel very strong. Some other things that a pulse might feel would be weak or thready. Thready is when the heart rate is usually it's so fast that it just kind of melts into the other beat from one beat to the next. So you can't see that clear defining pulse or pump of the pulse. So somebody with atrial fib might have a pulse that's considered thready. So common pulse places you'll find would be, of course, the wrist in an adult. This is our radial pulse, and it's checked in all patients 1 year or older. Once again, use your fingers on the thumb side of the wrist, just above the crease there, and feel the pulse to find the radial pulse. Our next pulse location might be the brachial pulse, and this is where you check the pulse in a 1-year-old or less than 1-year-old, and it's in the upper arm. These are a little bit more difficult to find. You've got to kind of put your fingers tips a little bit deeper past that muscle to be able to feel the artery. And here's where you would check a brachial pulse in an infant. The carotid pulse in the neck, it's felt in the carotid artery, and it's on either side of the neck. And this would be the first place you would check a pulse in an unresponsive patient. That's because it's the last pulse to be lost. Count the pulse for 30 seconds, multiply by 2. We do 30 seconds because that gives us a long enough chance to look at the rate and the rhythm and the strength of that pulse. If you see any irregularity, you would continue to check it for the full 60 seconds. Respirations. On vital signs, that means we're going to count how many times they breathe in and out. And once again, here we're going to look at rate and quality. Here's a person checking um, a pulse, but what's really interesting is he's also assessing the respirations. So you don't want a person to know that you're really counting their breaths, because what happens when you're counting breaths and the person realizes it is that they tend to be able to control their respirations, and as kind of a natural thing, it's hard to be natural or consistent if you know somebody's watching you. So when you're checking that pulse, also just hold on to that pulse a little bit longer, and after you're done counting the pulse, then count the respirations, and the person's going to be thinking that you're also just checking a pulse a little longer. Sometimes a patient heart will have an electrical problem and beat more than 2 times a minute. Why is the pulse so weak in such a patient? Just a critical thinking thought. Once you get into actually checking real patients, you might come into a very fast pulse, almost faster than you can count. And this is called a weak or thready pulse. Respiration rate is the number of times a patient takes a breath, and the rate is classified as either normal, rapid, or slow. So we're going to have either tachypnea, bradypnea, or just normal respirations. There's also something called agonal respirations, and this is not adequate breathing at all. It is the gasping breath of somebody that is dying. So a normal rate for adult at rest is between 12 and 20 breaths per minute. That's an average. It kind of depends on the person's size, their age, physical condition, sometimes whether they're anxious or not. This can all influence our breathing rates. So too fast or too slow respiratory rates might require some intervention like oxygen, or if it's too fast to actually inflate the alveoli in the lower lungs, then we may have to assist ventilations. Respiration quality, 4 categories here. We've got normal respirations, or we have shallow respirations. Labored, if they're using all their muscles of respiration to try to breathe, we call that labored. And noisy respirations, if they're breathing and you can hear them. If you observe irregular respirations in an unconscious patient, you should report it on your documentation, and you should trend it. So, 4 respirations, count it after assessing the pulse rate. So count the number of breaths taken over 30 seconds, multiply it by 2. You want to note the rate, the quality, and the rhythm of the respiration so that your documentation is complete. Skin, we're going to look at color, temperature, and condition of skin. This is going to give us valuable information regarding the circulation of the patient. Best places to look at the color of the skin is in the nail beds, or inside of the cheek, or inside of the lower eyelids, and the mucosa is what they call it. Infants and children, you can look at the palms of the hands or the soles of the feet, and that's also where you're going to check capillary refill, where you press on the nail until it blanches a white, and then when you let up, it should turn the normal color again within 2 seconds. If a patient has dark skin, you're going to look on the mucosa or the lips uh, and the nail beds. Some abnormal skin colors might be pale, cyanotic, flushed, or jaundiced. So somebody that's not getting enough oxygen might have that blue-gray cyanotic color. Somebody with a fever might have flushed skin, and somebody that is jaundiced probably has a liver or hepatitis problem. Temperature. Feel the patient's skin with the back of your hand. Note if it feels warm, hot, cold, cool. And this is somebody that's checking the skin temperature. You notice they've pulled their glove back and they're feeling skin temperature with the back of their hand. That's the proper way to do it. For pediatric kids that are under 6, it's necessary to evaluate capillary refill. This is a reliable sign in children, but it's not so reliable in adults. Anything can affect it, such as cold or poor circulation, which kids don't necessarily have poor circulation, so that's why it's so reliable. Adults, we have anything can really affect, our circulation, cold, uh, hypoxia. So press the nail bed on the hand or foot, release it, and see how long it takes for the color to return. It should be less than 2 seconds. If it's longer than that, we call it a delayed capillary refill. Pupils. So this is checking the center of the eye where the pupil is. In a dim environment, the pupil will generally dilate. So shining a light in it, you would see that constriction. We call that reactivity. This doesn't work in a bright environment where the pupil is already constricted. So if you're outside, you may not be able to assess pupils and the reactivity of the pupils until you get them inside and in a nice dim environment, and then that pupil will dilate to where you can shine a light in it and constrict. We're going to look for the size of the pupil, and you can compare it. Usually on your pen light, there's a little chart on the side on most of them. You're going to look and make sure both sides are equal, both pupils, and you're going to look as to whether or not they react to the light. Note the baseline size. Once you shine the light in, cover one eye, shine the light into the eye, and then repeat the process in the other eye, and note that. You can see on this pen light, you see the little dots that are on the pen light. Those are a pupil chart so that you can compare the size of the pupils and you can measure them. 1, 2, 3, 4, 5 is the size numbers, and you can document what size the pupils are in comparison. Here is a picture of constricted pupils on top. This is where they're already constricted. That might be somebody that's taken a narcotic or has overdosed on an opioid might have constricted pupils. The second picture is dilated pupils. A person with dilated pupils might have taken some type of stimulation medication. And then unequal pupils on the bottom. There is a condition called anoscoria where the person has unequal pupils, but generally it is considered abnormal to have unequal pupils, and then the pupils that would indicate a head injury in a patient normally. Assessing the pupils, unequal pupils can also be done by dropping a medication into the eye, it can cause the pupils to dilate. You've probably had that in the eye doctor. But for the most part, unequal pupils could indicate the patient has a head injury. Blood pressure. This is the force of blood against the walls of the blood vessels. Top number is when the heart is at work and the muscle is contracting. The bottom number is when the heart is resting and filling with blood. A normal pressure uh, is it can vary from patient to patient, but generally systolic blood pressure is no greater than 120 and the diastolic is no greater than 80. But changes in that can indicate something significant, but once again, you have to trend vital signs. So blood pressure is measured with something we call a sphygmomanometer and a stethoscope. Generally, you can have a cheap cuff and a better quality stethoscope is preferred because you want to be able to hear well. The cuff of the blood pressure cuff should cover at least 2/3 of the upper arm from between the elbow and the shoulder. Here's a picture of a blood pressure cuff being put on. This one is sized properly. It looks like it fits. You notice the arrow on the blood pressure cuff? There's an arrow and it would be placed over the brachial artery. And a lot of times the cuffs will have two arrows, depending on whether it's on the right arm or the left arm. So the blood pressure, we put the cuff on the patient's upper arm. We place the lower edge of the cuff about 1 inch above the crease of the elbow. We want that arrow, which is where the bladder is located, over the brachial artery. All right, so taking the blood pressure, we want to prepare your patient and then put your cuff over the elbow in the upper arm, and you want to find where the brachial artery is. So position your stethoscope so that that arrow that's on the cuff, position your blood pressure cuff so that the arrow is pointing to where that brachial artery is at the crease of the elbow, and then position your stethoscope there and place the diaphragm of the stethoscope directly over that pulse or the medial anterior elbow. So here's a picture of it, and you can see the arrow is for the right arm, which this cuff is on the right arm, is placed right over that brachial artery where he's palpating, and then he's going to put his stethoscope right there and begin to listen. So inflate that cuff, and you inflate until the gauge actually reads 30 millimeters higher than the point where you lose the sound of the pulse. Slowly release the air from the cuff. This takes a little bit of practice. And when you hear the first sound of the pulse as it comes back, you look at that reading on the gauge. That is going to be the systolic reading. You continue to listen to that pulse until it goes away as you deflate the cuff. That sound will turn a little bit dull, might be muffled for a bit, but when you quit hearing the sound of the pulse, that would be the diastolic pressure. So the systolic pressure is when the pulse rate, you start hearing it. The diastolic pressure is when you quit hearing the sound, and then record these measurements and the time. Um, there's a second way to determine the blood pressure, and that's by palpation. If it's really noisy and you can't hear anything, or you don't have a cuff or a stethoscope to listen with, then you can take the cuff and put on the patient, same position as if you were auscultating a blood pressure. You find the radial pulse, and you're going to feel that pulse as you inflate the cuff. When you lose that pulse rate, or when you quit feeling that pulse, slowly deflate the cuff and then note when the radial pulse returns. You will only get a systolic blood pressure for a palpated blood pressure. For pediatric patients, any child that's less than 3 years old, it's it's not considered required. It's not abnormal to forego a blood pressure. They're difficult to get in kids and they're unreliable, whereas capillary refill is a better indication of their circulatory status. So, some useful information for kids is more how they appear, their respiratory status, and whether or not they're unconscious. So be sure and position the cuff and then inflate it and get a good record of the systolic pressure as you slowly deflate the cuff. Temperature readings. Uh, this is not a common thing to take on an ambulance pre-hospital, but with the COVID uh, years of COVID that people have gone through, we've become more common to carry thermometers on the ambulance and take a temperature. The temperature is the chemical reaction of the other activities that take place inside the body. Somebody with a fever might be fighting off an infection. So the core temperature is actually the level of heat inside the trunk of the body. Core body temperatures or temperatures in general will vary depending on where you take them. You can take a temperature rectally or in the armpit or in the mouth, or more commonly you see that tympanic temperature that's taken in the ear. Normal temperature depends on the time of day, the activity level, the age of the patient, and where you take it at. And here's somebody taking a temperature electronically. You see it's quicker to produce than taking it with the old style glass thermometer. You will cover the probe with like some type of plastic and have that disposable so that it's, you know, protected from one patient to the other. Monitoring devices. Oxygen saturation is a device that we will see what a patient's SpO2 reading is, and that's the number of oxygen molecules present on the red blood cell. It's measured with a pulse oximeter. It shines a light generally through the fingertip. You put a little finger probe on the patient, it'll shine a light through the finger and it's counting the red blood cells, the number of oxygen molecules that are on them as they pass through that light. So this is a picture of a pulse oximeter applied to the patient's finger. It gives you two different types of information. You can see a pulse rate on there. The bottom number is the heart rate. The top number is the SpO2 in a percentage those are the oxygen molecules that are attached to the red blood cells. And in this patient, they've got 98% of their red blood cell that's carrying oxygen molecules. So, when do you use a pulse oximeter? Um, the protocol you have should govern when you use it, but it's not uncommon to use it on every patient. I would argue that to get a good, a thorough assessment of a patient, you probably should have a pulse oximetry. Anybody specifically complaining of respiratory problems or at risk of hypoxia, and that's pretty much everybody, should have a pulse oximeter. When you interpret the reading on the pulse oximeter, normal is generally 96 to 100. However, a patient that has COPD might have a lower oxygen reading per normal, and so they might have a reading even as low as 90 to 94%. And it's not unusual for people to be about 93, 94%. It's for you to make sure that your patient care, you try to maintain oxygen levels above 94%. So in a mild hypoxic patient, you might put a nasal cannula on and just a little bit of O2, whereas somebody more severe hypoxia might require even a bag valve mask if they're not breathing adequately, or if they are breathing adequately, a non-rebreather at 10 to 15 liters. Accuracy of the pulse oximeter can be affected by a lot of things. So always take into account the entire condition of the patient and not just one reading. Shock, hypothermia. So if their fingertips are cold, you're not going to get a very good reading. If for some reason they don't have good circulation through their finger, you're not going to get a reading. Nail polish, especially a darker nail polish, the light won't be able to shine through to get a good reading of the oxygen saturation. Anemia, where somebody doesn't have enough red blood cells circulating through their body, excessive movement, all these things are things that can affect your pulse oximeter reading. Blood glucose meters. This measures the quantity of glucose in the bloodstream, and it can help to identify diabetic emergencies. This is what a glucometer looks like. You would have a test strip that gets inserted into the machine, and those are lancets to the right where you would prick the patient's fingertip to get a blood sampling. So you have to have permission from medical direction to use it as a part of your protocols. Monitors are calibrated and are actually controlled by lab, as far as it is a lab sampling. And so the monitors have to be calibrated, and they also have to be checked daily for accuracy. And so, as a part of your morning checks or your daily rig checks, you would check the accuracy of your blood glucose meter. So, prepare your device, get a test strip, get a lancet. You cleanse the patient's finger with an alcohol prep. You actually prick the finger with a lancet, and then you would wipe the first sampling of blood off with a little wipe or a gauze pad, and then you get a second set or a second blood drop that you would actually put onto your strip and analyze that sample, and you should get an accurate reading with that. A normal glucose is considered anywhere between 70 and 100. It depends on the manufacturer's instructions also, but in general, most people are 70 to 100. Also, capnography is another thing that's commonly taken now. You can take a capnography is the measurement of the amount of carbon dioxide that the patient exhales. A normal level is 35 to 45 millimeters of mercury. We do abbreviate that as ETCO2. It is an accurate indication of whether or not the uh, body is perfusing or metabolizing the oxygen that it takes in, because it's measuring the carbon dioxide that is the waste product, and that's what we're exhaling. So the methods for capnography, for a breathing patient that's breathing on their own, is a nasal cannula that's specially made as a little, like, um, portion that covers the mouth a little bit. And as the person exhales, it takes a sampling of the air and a percentage then of the carbon dioxide. In a ventilated patient, somebody that you're using a bag valve mask on, there is another device that you can put on the advanced airway and measure the exhalation, entitled CO2. So documenting your vital signs is important. This is the last thing you should do, is make sure that you've got your trends and vital signs all documented and accurate. For the most part, 3 sets of vital signs is preferred on every patient that you transport. One in the beginnings, we've got a baseline, one at the end, and one during the middle. But if you have a very short transport, like, less than 15 minutes, then you might only be able to get like the baseline and then a final set. At a minimum, you do want 2 sets on every patient. Even your nursing home transfer patients, you should have 2 sets of vitals. One to tell them, to document how they were when you first got their care, and then how you left them at the end. Um, Generally, remember in your documentation, stable patients will be documented every 15 minutes and unstable patients every 5 minutes in your trends. And that is our lecture on uh, vital signs and how to take them. We will be practicing this in classroom. So if you have a blood pressure cuff and a stethoscope of your own with you, which you would like to practice with, be sure to bring it to class. Thank you.